Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Courtney Smith. During this episode, Professor Geoffrey Dusheiko from the University College London Medical School and Dr. Ming-Lung Yu from the Kaohsiung Medical University in Taiwan will discuss key racial inequities of care that lead to undertreatment for migrant populations and other racial minorities globally with or at risk for hepatitis B. Additionally, they will discuss plans to improve engagement across the care continuum and strategies to combat implicit racial biases that affect optimal HBV care. This podcast is part of a larger educational program titled Tackling Racial Disparities in Care for HIV and Viral Hepatitis. Please visit the show notes for this episode to follow along with the slides and for more information on Professor Dusheiko and Dr. Yu. Now, let's get started and hear what the experts have to say on this important topic.
Thank you very much for the invitation to address this webinar. Our program consists of 4 core themes. We're going to look at differences in the burden of hepatitis B globally, but only in the context of migration from those areas to perhaps lower endemic areas, to bring out some of the disparities in care. These include suboptimal engagement with hepatitis B care and the consequences. We're going to touch on the important subject of the stigmas associated with hepatitis B care and look at some of the strategies that could be invoked for overcoming these minority and racial barriers to hepatitis B care. Clearly, this audience will know that there are differences in the burden of disease globally. This is not going to be examined exhaustively, but we know that there are high endemic areas and low endemic areas, as well as moderate endemic areas for hepatitis B. It's important to point out, as this audience will know, that migrants from endemic regions and minorities within low endemic areas have a disproportionate burden of disease due to hepatitis B. Overall, globally, we know that chronic hepatitis B affects between 250 and 290 million people. But the important routes of migration at present, which have been occurring for some time, from Eastern Asia and Sub-Saharan Africa to areas either of themselves high endemicity or more usually areas with a lower endemicity, perhaps effacing some of the needs for care that migrants require in those areas. It's important to point out that this increase in hepatitis B prevalence associated with migration is of course associated with chronic liver disease, and a higher incidence is noted amongst these communities who immigrate to Europe or the US from these regions. On top of the fact that there is severe underdiagnosis and undertreatment of hepatitis B globally, there is an important equation here that there is important severe underdiagnosis in migrants from those endemic regions. And until we remove that disparity, the disease remains silent in those groups, and the consequence is late presentation in those groups with advanced disease, a consequence we'd like to avoid. To give you some examples of prevalence of hepatitis B immigrants, the HBsAg prevalence in sub-Saharan immigrants in Western Europe ranges from 7.4 to 15%, depending upon the country of origin in sub-Saharan Africa. In Greece, it has been documented that between 11 and 15% of Albanian refugees have chronic hepatitis B. There is a large Turkish community and has been for some time in Germany. The community comprises 20% of the whole population, with a hepatitis B prevalence that is high, 5%. And in England and Holland, a prevalence of 8.5% has been documented amongst Chinese immigrants. Here on this slide, I'd like to bring out the important fact that the cascade of care for hepatitis B globally, and of course the cascade of care in countries of migration, is poor. We know that there are some 250 to 200 million people infected with chronic hepatitis B. It is thought by the WHO that perhaps 1/3 of them might be eligible for treatment because of active hepatitis B. An abysmally low number, around 10%, are thought to have been diagnosed with chronic hepatitis B. That's around 30 million. The proportion is particularly low in sub-Saharan Africans. We also know, and this is striking, that perhaps 1.6% of that burden of disease are on antiviral treatment. This is a severe disparity in care. It's a higher disparity than we observed with HIV, and also given the improvements in DAA therapy for hepatitis C, it's a higher disparity than we observed in hepatitis C. So this needs addressing both globally, but also in countries of migration and amongst ethnic minorities with a higher prevalence.
The HBV infection is an immense disease burden in Asia Pacific region. 60 million in Southeast Asia and 160 million in West Pacific region. They account for 60% of the global HBV population. Every year, 0.65 million people die of HBV-related liver diseases in Asia Pacific, which accounts for 80% of global HBV-related mortality. Taiwan is an HBV hyperendemic country with prevalence rate of 9.5%, and the 2.2 million people are living with the virus in 2016. The HBV prevalence rates were even higher in several minority population in Asia Pacific. Similar to the situation in the UK and United States, the reports from Japan and South Korea show higher HBV prevalence among female immigrants, especially those from Southeast Asia and China. Data from China, Nepal, and Thailand also observed high HBV prevalence rates among people living in high mountain areas, especially those of indigenous people. 70% of Nepal were HBV carriers, and 48% of their children were positive for HBV surface antigen, because only 1/3 of the children complete full HBV vaccination. In Australia, indigenous population and Asian immigrants also had high HBV prevalence rates than those from the European ancestry. There are more than 10 indigenous tribes living in mountain areas and small islands in Taiwan. This study investigated the surface antigen prevalence rate among 5 ethnic groups before HBV vaccination program in Taiwan. In Taiwan, indigenous people had much higher surface antigen prevalence rate than that of non-indigenous people, 22 to 25%, versus 10 to 16%. We also found a lower disease awareness in the indigenous population. All of these results demonstrate a huge disease burden of HBV among minority population in Asia Pacific, indicating there are racial disparity of HBV care in minority population and needs the right policy to overcome the hurdle.
What is being shown on this slide is a cross-sectional analysis of an index of effective policy towards eliminating hepatitis B based on WHO guidelines for eliminating the disease burden of hepatitis B in heavily burdened countries. The authors asked, are the right policies in place? They used 11 policy actions to weight the answers. There's some countries at the top right of this curve, for example, Australia, New Zealand, Spain, perhaps the United Kingdom, where it is considered that the right policies are in place to manage hepatitis B. And there's some countries burdened by a number of factors, socioeconomic factors, war, etc. For example, at the bottom, Syria, Sudan, Yemen, the Gambia, Somalia, where the wrong policies or no policies are in place. Remember, this is a cross-sectional analysis. The question has to be asked. We can rank countries and territories, but how carefully can we rank policies towards migrants in these countries, as shown in the top right? And that's something we'll try and address with the remainder of this webinar.
So to tackle the disparity of HBV care in minority population, we have to understand the amenities in each care category. In this slide, the challenge of HBV care in remote far north Queensland, tropical Australia. Of 602 indigenous people with chronic HBV infection, only 40% engaged in HBV care. 65 engaged patients who met the criteria for antiviral therapy, only 2/3 of the eligible patients received antivirals. 251 patients met the criteria for HCC surveillance by the national guidelines, but only 26% of them received screening and monitoring. So the data suggests the optimal engagement of HBV care in indigenous people in remote areas of Australia. The liver disease and hepatocellular carcinoma are important contributors to the mortality gap between indigenous and non-indigenous Australians. This retrospective cohort study observed the indigenous hepatocellular carcinoma cases were younger, more female, more HBV infection, high rurality, low socioeconomic status, high comorbidity burden, and less chance curative tumor therapy. The 5-year survival was a significantly low in indigenous HCC patients, 10% versus 17%. The data provides to help design and implement the policy to improve liver care for minority population to close the HCC mortality gap. In 2016, the WHO calls for the elimination of viral hepatitis by 2030. The HBV elimination is defined as a 95% reduction in incidence and a 65% reduction in mortality. To achieve the goal, we have to diagnose more than 90% of HBV infected patients and to treat more than 80% of HBV people who are eligible for antiviral. But until 2019, only 2% of the HBV patients had disease awareness, and only 0.2% was treated in Southeast Asia. The status is better in West Pacific area. Taiwan has implemented a series of strategies in the diagnosis and treatment reimbursement for HBV infection since 2003, and reached a 64% disease awareness. However, but only 10% were diagnosed and treated, indicating a huge gap remains towards the HBV elimination. The WHO goal also requires a reduction of surface antigen prevalence rate to less than 0.1% in children with age less than 5 years old. It depends on to prevent mother-to-child HBV transmission, including more than 90% coverage of first dose vaccination within 24 hours, more than 90% for age 1 year, and early antiviral prophylaxis for HBV pregnant women with high viral load in the third trimester. The global coverage rate of 3-dose vaccination in age 1 year was near 90%. However, less than half completed the first dose within 24 hours in Southeast Asia. Taiwan is the first country conducting universal mass screening vaccination, HBV vaccination in 1986, with coverage rate of more than 90% in first dose, full dose vaccination, and HBV, and started to reimburse antiviral therapy for HBV pregnant women in 2018. Under such high coverage rates for first dose and full vaccination in Taiwan, the HBV prevalence rate decreased from 10% to 1% 20 years after mass vaccination program. However, there's still disparity in the minority of the Taiwan. In this community survey of indigenous and metropolitan children with age less than 13 years old in 2005, most of the prevalence rates of surface antigen and anti-core antibodies were significantly higher among indigenous children, 3.2% and 10.7% than in the metropolitan children, 0.2% and 1.7% respectively. The higher HBV carrier rate among the indigenous children might be due to the substantial low coverage of vaccination program in rural areas, the higher maternal HBV rate, and potential genetic basis for low immune responsiveness. This is the annual report of Australian immunization data for children with age less than 5 years old in 2018. The assessment of fully vaccinated coverage at age 12 months, including 3 doses of DTP, polio, Hep B, influenza type B, and pneumococcal vaccine. Although the fully vaccinated coverage rate in the indigenous children, the orange line, increased from 85% in 2009 to 92% in 2018, it remains persistently lower than those of the non-indigenous children. The disparity in on-time vaccination between indigenous and non-indigenous children, such as the second dose of DTP and the first dose of MMR, could reach as high as 10%. The data highlight the vaccine coverage gap for minority population in the rural area. A low response rate to HBV vaccination was also observed among indigenous people in Taiwan. More than 1,800 fully vaccinated children with ages between 3 to 6 years from Aboriginal and non-Aboriginal rural villages were surveyed for HBV vaccination response. Anti-HBs antibody clearance rate was 55% in Han Chinese children, 52% in mixed ethnicity, and down to 43% among indigenous population. The right-side study evaluated the response to booster HBV vaccine in adolescents who had full HBV vaccination 15 years before, but negative for certain antigen, anticore antibody, and anti-S antibody. Again, the booster response was 80% among Han Chinese, 71% in mixed ethnicity, and down to 63% in indigenous people. Understanding the ethnicity difference in response to HBV vaccination might help us to develop and implement the effective policy for HBV control in minority population.
Dr. Hughes pointed out some of the problems that exist even in a country like Taiwan with a very high awareness and effective policies in place for hepatitis B. What are the problems in Europe, for example, that are impairing detection and management for minority groups, migrants, and discriminated groups? Generally, there might be a lack of awareness of hepatitis B, and this varies amongst different populations, but in some, there is a poor awareness of hepatitis B. There's unawareness of the transmission of the disease, the fact that the disease can be prevented, and the disease can be effectively treated. In some regions, unfortunately, this also reflects a lack of trust in the medical system, in doctors, nurses, and medical care, which we need to work hard to overcome. Migrants, refugees might often be in a lower socioeconomic position and might be below the radar of healthcare services and may choose to stay below the radar, unfortunately, for a variety of reasons. Some cultural groups may still prefer, at least initially, other forms of healing and not seek care appropriately and early. And most importantly, testing in migrant patients and ethnic groups is, in far too many countries, simply ad hoc. There's no systematic testing opportunity, and this is an important opportunity which public health authorities need to address in such countries. There are also several reasons for avoiding health-seeking care. These are fear, for a variety of reasons that might exist amongst migrant populations and ethnic minorities. A mistrust, as pointed out, misconceptions sometimes that a group might be inappropriately be targeted and stigmatized, and this leads to further stigmatization and some denial. In many cases, inadequate financial resources, not having the insurance, not having the time and the capacity for health-seeking care will impair care. There may be low health literacy, and in particular, low literacy regarding the prevalence of hepatitis B in a community and the consequences. There may also be some confusion. We're not explaining the disease well enough to ethnic groups, and more we realize that there is suboptimal communication amongst ethnic minorities, migrant groups, and healthcare professionals. So what are some of the ingredients? Well, Western countries, as pointed out, have become lands of immigration from sub-Saharan Africa, North Africa, Eastern Europe, Asia, and Central America over the past decades. Asylum seekers often seek the most terrible persecution, war, genocide, and poverty in their countries, and arrive in the country scarred and often destitute. The conditions that pertain to these migrants and refugees often do not favor, let's face it, easy assimilation or integration into the host country, for language barriers and other cultural barriers, and sometimes prejudice. Some groups are frequently poor, unemployed, and would choose, understandably, to continue the cultural and religious traditions of their country and of their communities. They may not speak the language of their host country for some time and have to rely on first-generation born relatives. And we may be deceptively be confused by the fact that there is a healthy population who migrates. They show a healthy migrant effect. Those who are healthy are able to migrate, but still may harbor a chronic hepatitis B or other blood-borne viruses. So to summarize, for example, for African immigrant communities, these are some of the interconnected and interrelated barriers that prevent good management of hepatitis B, including healthcare access for the reasons I pointed out, the stigma, discrimination that may pertain, religious values may come into the equation, cultural norms may affect health-seeking behavior, there may be perceptions towards the establishment and towards prevention. Knowledge is poor amongst certain communities, despite the fact that they may originate in endemic areas, and there could be myths regarding hepatitis B.
Now we will listen to audio clips of an anonymous patient sharing experiences on disparities in HBV care in Africa and ways in which those barriers can be reduced. The first question is, as a patient, what are your perspectives on biases in HBV care?
It's a very big problem in Africa. Anytime you say, okay, you are hepatitis B positive, nobody will like to eat with you anymore in that place because they think eating together with you is going to transfer or transmit the hepatitis virus into your body. So some people will not even want to exchange pleasantries. They will not want to hug each other. Because of that stigma, you don't have any interaction with any other person again. They will isolate you completely. So that stigma is what is really causing problems.
The second question is, what can patient advocates do to reduce health disparities in HBV care?
About the awareness of hepatitis B and so on like that. People need to go for tests. Even if they are not sick, they need to go to the hospital for checkup. I think that vaccination, taking vaccine is what we need to admonishing people, especially the Black communities and the Asian communities, because that is where we have a lot of hepatitis B patients, Asian people as well as the African American.
My great pleasure to turn things back over to one of our faculty speakers, Dr. Dusheiko.
Thank you, Courtney. We heard in those clips two patients articulate two important aspects, stigma and a lack of awareness amongst communities. And we have to work extremely hard to overcome these problems. Problem arises at several levels. This is a survey that was done amongst almost 420 general practices in the United Kingdom. I remind you that migrants automatically qualify for general practice family care. There's no restriction to the care. But a group from Public Health England, as it was previously known, have surveyed general practitioners, physicians, and nurses for their knowledge, attitudes, and action towards improving healthcare, diagnosis, referral, management for individuals with blood-borne viruses, including, of course, hepatitis B, HIV, and hepatitis C. So remember, this is a survey of attitudes and knowledge and understanding of the healthcare professionals. Their perception was that the language barriers and the cultural barriers faced by migrants are the most important barrier to testing, the appropriate interpretation of the diagnostic tests, appropriate action upon those tests, and linkage to care. That's interesting. There were other factors the healthcare workers perceived as barriers, including patients' information, knowledge, psychological barriers such as fear and prejudice, etc. But language and cultural were the most important barriers perceived by healthcare workers to be impairing care.
Not only the stigma and not only the lack of knowledge, also the poverty can be significant barriers to screening, diagnosis, treatment, and prevention of many infectious diseases, including HBV, especially in resource-constrained settings. It is because that HBV is more prevalent in disadvantaged groups, which becomes a hurdle to seeking for HBV care due to lack of budget and strategies. Also, lack of knowledge in the transmission routes and treatment of HBV infection due to the language and cultural barriers, poor awareness or misconceptions might lead to the internalized and structural stigma, and frequently have negative impacts on mental health, education, employment, and relationships, and even result in negative attitude from the healthcare provider. Data from the 2023 articles show that HBV-related stigma is common in Asia Pacific region and also among the Asian immigrant communities. Up to 60% of the people had internalized stigma for HBV. The negative perception included feeling embarrassed, afraid of having trouble to families. Some people hesitated to contact each other, not put together due to fear of infection. And up to 1/3 of people had structural stigma for HBV. People fear that HBV infection will affect their employment opportunities, leading to loss of their job due to discrimination from employees, the workplace discrimination. Also, some HBV carriers would not inform doctors or dentists of their HBV status due to afraid of being denied for health care. Obviously, the key cause of the stigma come from the misconception about the routes of transmission and the fear of infection. Lack of knowledge in HBV transmission also has impact on the attitude of healthcare providers. An investigation with questionnaire among healthcare providers in Cameroon 2017 showed that 1/3 of healthcare workers had incorrect knowledge on the route of HBV transmission. And more than half of the healthcare providers had a negative attitude on HBV care. Another two studies also revealed that 18 to 27% of nurses expressed unwillingness to care HBV patients in Japan and Vietnam. This data indicates that comprehensive and timely education is urgent for not only in the general population, but also for the healthcare provider to overcome the HBV-related stigma.
By now, I think we've tried to show some of the enormous barriers that occur amongst ethnic groups, racial barriers for appropriate hepatitis B management. What are some of the key strategies that could be adopted by host countries to overcome these barriers? Well, one easy implementation is universal vaccination in the host country. We've seen the disparities in data that exist in Taiwan, but it's important that we emphasize vaccination. Prevention is easier than treatment. Prevention is easier than cure. And this is a prime objective to ensure that ethnic minorities accept vaccination and that we ensure birth dose, universal birth dose, full course vaccination in migrants and ethnic minorities. The second point is screening. Screening at the moment is ad hoc. There are recommendations, for example, in the UK by NICE, that populations who originate from regions where the prevalence of hepatitis B is higher than 2% should be screened. But this is very ad hoc. It's improperly done. We think that the data are poor. We need to look at the costs and logistics of appropriate screening, emphasize awareness, both amongst the communities themselves that are relevant, as well as emphasize awareness amongst healthcare professionals and put systems in place, if necessary, digital computer systems on a general practitioner's computer that would ease the logistics and automate appropriate screening for hepatitis B and bloodborne viruses in host countries. This should be easily done. It's important to establish a non-prejudicial environment, overcoming that stigma, the fear of discrimination that you heard about, so that we can elevate the problem without aggravating the problem and ensure that patients with chronic hepatitis B are appropriately coming forward for testing, appropriate diagnosis, complete workup, and, where necessary, treatment and prevention. This would avoid the failures that are currently translating in many parts of the world to late presentation and the dire morbidity that is associated with advanced liver disease and hepatocellular carcinoma due to late presentation. There are examples where uptake of viral hepatitis testing has been improved in a culturally sensitive and appropriate manner. This paper, published by Kelly et al. In the United Kingdom, examined a new methodology for improving the uptake of viral hepatitis testing in South Asian migrants in a face setting. Essentially, their paper details how an appropriate film was made to educate individuals in a face setting regarding the problem and morbidity from viral hepatitis. Patients were encouraged to be tested by dried blood spot testing in this environment immediately after viewing the film, and the effectiveness of this measure, as an example, was measured by a pre and a post-film questionnaire. The paper gives all the details. Time does not permit to analyze all of the results, but clearly such an important, relevant, culturally sensitive, fairly easy methodology can improve interventions for case findings in different settings. So we need to emphasize all the measures that are required to improve management. Firstly, a recognition by both the communities affected as well as healthcare practitioners at many levels of the epidemiology of hepatitis B in our migrant and different racial groups. We need good data analysis, sadly lacking even in countries with advanced public health surveillance systems. Community education amongst minority groups is a priority to overcome the fear, the stigma, and the concerns that minority groups would have. We need to make these culturally relevant community interventions by engaging with appropriate members of that community. We look for the assistance of social services, voluntary operations, and cultural mediators to establish trust. We look to overcome all of the potential clinical, often severe psychological, as well as the legal management of vulnerable groups who have found their way to our shores. And this should be a major objective of good government and good healthcare governance with the appropriate focus in these groups. And that educational focus would include explanations at the right level of the basic epidemiology of the infection, routes of transmission, the fact that hepatitis B can cluster in households, sexual transmission, the important route of mother to child transmission and how this can be prevented, parental transmission by needle stick and other sources, including drug use. We need to emphasize the importance of systematic, appropriate screening that will identify and diagnose a higher number of individuals that have been diagnosed hitherto. We need to ensure that linkage to care, providing available treatments, are provided without difficulties of access to all individuals, never forgetting the emphasis should be on prevention and vaccination, and in most countries in Western Europe, for example, an explanation of the costs, which would largely be neutral or minimal to patients with chronic hepatitis B.
There are also two strategies to improve the accessibility of health service for indigenous people. The first one is to address the physical and economic barriers, provide local health service, transportation service, provide the flexible service time out of the work, and home visit service for those who stay at home. Also, financial support is very important. The second strategy is to address the cultural competence, accessibility, and appropriateness, building the clinical relationship based on the trust and the mutual respect. It's very important to have the indigenous health workers to deliver the culturally safe service. There's no assault, challenge, or denial of their identity and experience. Implement strategies supporting the cultural competence and safety, such as appropriate communication styles and working through the kinship network. In Taiwan, the NGO plays a critical role in making great contribution in HIV care in the past decades. There have been 15 NGOs dedicating in HBV screening and patient education since 1994. Taiwan Liver Research Foundation was established in 1999. We set up several outreach teams with volunteer hepatologists, nurses, and technicians providing community integrated services in the HBV endemic areas and the underserved region in high mountain and islands. We have been providing education for general population and also healthcare provider and the medical assistance in HBV care, from screening, diagnosis, and linked care in the areas with insufficient medical resources. The Taiwan Liver Research Foundation also provides financial support of liver care for the people who live in the resource-constrained area. So, ladies and gentlemen, I would like to summarize the strategy to tackle barriers in HIV care among minority population here. The first one is comprehensive research to help us to identify specific barriers in each care cascade among different minority populations. The second one is to establish a national viral hepatitis program with special focus on minority population. Either direct government budget allocation to national programs or via the reimbursement by national health insurance system. Set up clear guidance and top-down the vision from screening, linked care, treatment, and prevention to local health authority and facility in rural area. The final one is to encourage NGO to engage the education, advocacy, volunteer community screening, and need care for people with disparity in HBV care.
So we've reached the end of this, but we now have a question and answer session. I believe we have some 15 minutes for questions and answers. We'd encourage you to submit your questions, and Dr. Yu and myself will do our best to try to answer them. I've got some questions up, Dr. Yu. You can see them as well, I guess. The first is, will the presentation be available after the webinar? I think that CCO can address that question, but I presume that's possible. The second question, Dr. Ho has asked, linkage to care is essential in difficult to reach groups. We've investigated this in Belgium and Asian populations, other populations ongoing, and sites of publication in 2020. I fully agree. Linkage to care is key. We have some preliminary data that we don't fully understand showing in our public health laboratory Sentinel system that substantial numbers of individuals who were tested for HBsAg, the diagnostic marker of hepatitis B, have not had a follow-up test for hepatitis B DNA. This either means that the individuals were not referred to a tertiary center where assuredly individuals would have a test for hepatitis B DNA to stage the disease, or were not tested for hepatitis B DNA in the practice, therefore demanding further onward referral. So there are gaps in the linkage to care, and we fully agree that this process requires the cascade of care from increased diagnosis and improved linkage to appropriate treatment being fundamental. I think there's a comment from Dr. Ho again, who says we see this as well. We have dedicated staff to guide patients who follow up and referral. I fully agree. I don't know if you'd like to comment, Dr. Yu, but this question and comment does require emphasis.
Yes, I totally agree with the opinion. Actually, there are similar situations in the HCV control. In the past, we tested anti-HCV, and if the patient positive for anti-HCV, we refer the patient to the clinic and test the HCV, but it's time-consuming and costly. So we developed a system so-called HCV testing, automatic test the HCV RNA for anti-HCV pulse samples. So I think we can also develop the similar strategies with the HBV testing to test the HBV DNA upon the sample were positive for hepatitis B surface antigen. I think we will be more convenient and speed up the diagnosis rate.
Dr. Yu, while we're waiting for some other questions to come in, I was, if you'll forgive me, a little bit surprised at the disparity between vaccination rates and HBsAg seroprevalence rates amongst the indigenous population of Taiwan versus, for example, the metropolitan population. Taiwan has long known of the problem of hepatitis B, has an excellent public health infrastructure that is focused on hepatitis B, has actually been exemplary in instituting vaccination. Is there a clear explanation for why the indigenous population have lagged behind some 30 years after the first introduction of hepatitis B vaccination?
I think the data come from the study in 2005. At the time, we think the disparity in the vaccination efficiency might due to the coverage rate of the first dose vaccination within 24 hours. So the public authority pursue the 95% of first dose coverage in recent years. And I think the second reason for the higher surface antigen prevalence rate in indigenous people might be due to the genetic variation. because some study demonstrates the difference in HLA determinants might have the impact on the immune response to the HBV vaccine. And actually, the Han Chinese and the Taiwan Aboriginal ethnicity is different. The Taiwan Aboriginal people belong to the Polynesian ethnicity. So I think maybe this is another reason. And the final one is that before the mass vaccination program, the Aboriginal people already have higher prevalence rates of certain antigen. So I think it's the third reason that the children from the Aboriginal region have a higher certain antigen level even after the mass vaccination program. But I think the situation become much better recently. In our recent study from the northern part of Taiwan, they show that almost no difference in the certain antigen prevalence rate between Aboriginal and the metropolitan children right now.
I see we're out of time. We thank the audience for their listening, their participation. I thank my co-speaker, Dr. Yu. We'd like to thank CCO for their excellent support and technical support. We hope you enjoyed this, and we hope particularly that this educational center will lead to a better management of hepatitis B in the groups that we've discussed today, and we will see improvement. Thank you very much, everyone.
Thank you.
Thank you very much, Professor Dusheiko and Dr. Yu. And thank you to the listeners for joining us. As a reminder, to view the full program, Tackling Racial Disparities in Care for HIV and Viral Hepatitis, and to download the slide set associated with this discussion from the Clinical Care Options website, please click on the link in the show notes. As always, thank you for listening.